Thanks, Natasha, for the nice words. Maybe a little too much, but I'll try to live up. So my biggest challenge today was whether to wear a tie or not. And I asked a local, and he said, no tie, it's too colonial. So I would like to address tetrahand surgery and try to do it from a scientific perspective and also show the underlying studies that is guiding and governing our surgical approaches, and also add a perspective of how to initiate a team that is an expert team that is seeing the patient together, and where the trans-professional knowledge is really going to be the power of our service. So as long as we remember the goal of the patient, we can proceed. We can even do experimental studies in the lab, and when that is solid enough, we have data that makes it possible to advance the field. As long as we remember the goals from the patient as expressed by themselves and follow that up, provide the outcome measurements, and also together with the patient tailor the treatment. So this is probably the most recycled picture that I have. This is Kim Anderson's analysis of a survey in more than 700 American spinal cord injury patients, indicating that hand and arm functionality is highly prioritized in this patient group. That's not a surprise to us, but it's an extremely valuable tool when we want to establish a team, a setting for seeing those patients in an expert team. It also gives us some argument and some ammunition when we talk with hospital directors and politicians to proceed and develop this surgical field to improve upper extremity function. With this in mind, we are aiming at adding value to the patient. We do that with the patient in focus, with the patient's participation as a consultant, to refine our expert team skills, so skill levels. The patient is also critical for understanding the sort of the softer arguments when we're considering surgery or considering a conservative treatment that can be quite demanding over a long time. With the patient and our team, we can reach out in all kinds of directions, from house doctors to therapists in the villages around the hospital or wherever, and make the awareness bigger and bigger over time. And also in Notteville, we have a PR unit that works with us also to reach out. We have established a system where we can see all the patients in the whole country within 3 months after injury. That means that we have to travel to Zurich and to Basel to also have the consultation on a regular basis. So that adds a continuity that makes it possible to report the outcome at a national level. It's also an internal quality control for us to make sure we're not having big dips, and if we have dips, we can analyze the reason for that. We also have a responsibility, since we're one of the few units in the world, there's not that many, maybe it's 20, to take care of the development and the research and make sure that the foundation for what we're doing is solid. And we have our focuses, and you can see there it comes into 6 different flavors here. It's about the biomechanics of the tendon transfer. That's sort of the fundamentals that gives us the numbers that we rely on when we are making decisions, because we are essentially playing with a rubber band that we position into a new position to act as a new motor. And that gives us a lot of freedom, but it gives us a lot of responsibility. So that is a big focus, the tensioning of the tendon transfer and understanding the biomechanics. Suture techniques, that sounds kind of basic. It is basic, but nevertheless, that is still a main issue. Because if we cannot rely on the suture, the therapist will not dare do the sometimes aggressive training that is necessary to allow the patient to do the complete motor relearning process. Surgical developments that includes these days a new landscape that's introducing and including the nerve transfer into the tendon transfer paradigm and merging them and optimizing the function based on these two techniques. When it comes to rehabilitation refinements, we are working closely with the FES Center in Knoxville. That means that we are including this as a natural component, for example, in the mapping of the motor points to provide a prognostic solid information to the patient, whether this is going to be a expected success of the nerve transfer or it's a little shaky. Nevertheless, you need to have this communication. So we are also using the electrical stimulation unit to build muscle bulk, in some cases to increase the stability of a joint, shoulder, for example, also as a treatment for shoulder pain, to reduce the dislocations, subluxations that is often happening with our patients. Outcomes improvement, that is our main focus, of course. And what we're doing is surgery that is basically about reconstructing the triceps function in order to get a three-dimensional reach out for the hand. It is the grip function, and grip function that is include coming around an object, but as much a release of an object integrated in a daily life setting. The spasticity part is it's a really big challenge, and it's a growing challenge because of a way increased number of incomplete tetraplegics. That means that we are facing pain, and we're facing swelling, and we're facing contractures unless we are intervening early in this patient. Surgery is also a solution, I wouldn't say, but it is alleviation at some point during this development. When it comes to neuropathic pain, that has been a big issue that we have focused a lot because we hear by hearsay that that's absolute contraindication for surgery. The good news, it's not. If anything, it is helping the hand function, probably because of the increased sensory-motor feedback in a function, at least partly functioning hand, that is somehow reducing the pain problem. So this is good to know. This is based on 37 patients undergoing treatment for neuropathic pain that wanted to have hand function restored. So it's a pretty solid database. Now, some of our patients, they come to us and say, I would like to have a hand function, but I'm not willing to do anything else. Provide a hand function in the most simple way. Then we have to remember that the hand function, what is hand function? Well, that's a total integration of the whole upper extremity. And so that's our job to present the complexity of a restoration and also to guide the patient and give all the background factors that are influencing the final outcome. That means the thumb control is a big issue itself. I think much of the failures in the early days of tetrahand surgery was providing a thumb flexor that was a thumb in palm as a resulting position, which is totally dysfunctional. Or it was a closed fist. So that means that we need to address the intrinsic, we need to address the thumb position, but we also need to address the wrist position, because that's the foundation for positioning of the hand, which in turn is relying on the elbow, and a very common donor muscle is the brachioradialis, as is usually providing the thumb flexion. It is originally an elbow flexor. That means that we need to have an antagonist for the elbows to stabilizing the elbow in order to get a thumb function. So it comes together. So we restore an elbow extensor, and that is, for us, that's usually a posterior deltoid to a triceps, and that adds reaching out possibility for the hand, but it also needs to address whether this is the correct operation, and also to address the timing. Because very often we see that our patient, they have like partly or completely winging scapula. That means that we also have to address preoperatively the serratus anterior and the rhomboid to somehow secure the position of the scapula in order to guarantee that the outcome of the tricep reconstruction is sufficient. And of course, trunk sitting position in wheelchair, trunk stability, compensation mechanism, trick movements, all of that should be addressed within this expert team. It's not until we have this complete expert team that we really have the full trust from the patient, because they see that we handle most of the aspects of the upper extremity and are aware of the pitfalls and the risks and all the considerations. So I would like to show you some basic data that we have collected. Some of this is preliminary results, but I think it's so updated, so we need to address it and we need to communicate it. This is about wheelchair driving, with or without triceps. And I think here we are addressing a future big problem, because we have an aging population in wheelchair. With or without triceps, they need tons of schooling, follow-ups, teaching the techniques, and also checking that up, that it is going in the right direction, and getting rid of all kind of personally invented tricks. Because in some population studies, they say that 60% of the spinal cord injured population, they have some sort of degenerative changes in the supraspinatus, which is a potential problem with disruption, dislocation, arthrosis further down the line. And with increased life expectancy, we need to address this and be aware of that, and also prevent that as well as we can conservatively. So we have done a study, or we have initiated a study in Notteville together with Ursina Arnett, looking at the kinematics with or without triceps. And in this case, it's with reconstruction of the triceps with a posterior deltoid. So you can see in this picture that the direction, the total force direction, is something different compared to the effective force direction. And I've just shown next pictures. These are the actuators around the shoulder. So there's tons of parts of muscles that are directly or indirectly contracting for stabilizing and optimizing positioning, balancing the shoulder. So this patient is driving the wheelchair forward 2 kilometers per hour at 15 kilowatts. So this is a pre-operative picture of the pattern, the motion pattern around the driving wheel of the wheelchair, with a lot of trunk flexion combined with a pumping style of pushing that has a direction with a relatively low angle of approaching the driving ring, compared to the post-surgery patient, which has this typical double loop style of motion pattern that is more normal and more effective. And if you look at the data of this limited case series at the moment, you can see that the push frequency is going down after restoring the triceps. The push angle is going up. That means that it's a tangential approach to the wheel, which is more efficient. That's why the patient can do less number of revolutions or pushes. And the effective force is more efficient. So taking that together, that shows a push pattern that is changed due to the mechanical adaptation after surgery that we judge is positive for the efficiency over time. Another aspect is, where is the contact surface, the contact force? Well, this ring is supposed to mimic the glenoid fossa. And you can see that the preoperative non-functioning triceps shows a tendency of the push force is distributed superiorly and anteriorly, and that is right at the point subacromial, which means that it's in the area of a potential impingement of the supraspinatus. While after the surgery, this is more centralized, and we think, we don't know, this is a hypothesis, but we think that this is a positive factor that we probably can also address conservatively by changing techniques to a certain extent. Nevertheless, it's interesting and it's promising, and it gives us a deepened understanding, I would say, of our challenges. The next thing I would like to address is the intrinsics. It's also sometimes a very forgotten part of the hand function. You know, if you power the hand with finger flexors, you have a non-uniform flexion of the finger joints. That means that the flexion will be initiated in the PIPs, especially if you have functioning EDC, finger extensors. And this is going to be also a new challenge for us, because we are successfully restoring the finger extensors at the moment through the supinator to interosseous posterior nerve transfer. So that means that we will almost be sure that we can have a finger extensor, but that means that we need to have an intrinsic to compensate for that. Otherwise, we have a guaranteed claw handing situation. So this is just an experimentation showing in a cadaver model the importance of intrinsics. That's sort of the summary. And with intrinsic, I basically mean the lumbricals. So that is a flexion of the MCP joint, extension of the PIP joint. That needs to be sort of the simultaneous activation during flexion of the fingers. Can be illustrated like this. So in that hand to the left, you see a patient trying to come around an object, a can, with straight MP joints. That means that the flexion when grabbing is going to take place in the PIP joint, and the opening is too small. While with an already secured flexion position of the MCP joint, they will all start simultaneously. MCP, PIP, DIP, and nicely come around. So that's a take-home message of that. Intrinsic needs to be restored and needs to be there. I will come back to that later. This is the tensioning type of studies we have done. It's a project that involves measuring the tension intraoperatively with a load cell, force transducer, connected to the tendon that has been released, and it's been going to be transferred, and we need to identify the tension where we want to have the maximal power. And we're using the helium neon laser in order to measure the sarcomere length, because if we shine that through the striated pattern of the muscle, we get a diffraction pattern that is mathematically correlated to the sarcomere length. So we establish the sarcomere length versus stress level to that muscle that's going to be transferred. And that way we can insert it into a position that will give optimal force. So through this study, we have learned a lot. We have learned, for example, that the brachioradialis muscle is much more stiff than the wrist extensor, the radial wrist extensor, ECRL. And we have here indicated 3.5 microns, that is near the optimal sarcomere length to generate force. So this needs to be considered. This basically means that the ECRL is a very forgiving muscle. You can play around with, put it in wherever you want, in whatever tension. That will take care of that because of the low level of stiffness. While the brachioradialis is really stiff muscle, so we need to find the point where to insert it. Luckily, we have a landmark for that, and that is exactly the length it is sitting in the inside position with a straight wrist at 3.5 microns. So it's sitting right at its optimum. So that is just bringing it back to that length. That's kind of information that we have gathered from the studies. Another thing we have observed is, for the brachioradialis, this is just an example, that the level of the lesion is a key factor. And we're probably talking about partial denervation or less cross-sectional, physiological cross-sectional area in these motors that are very stiff. So that's an observation that we're going to explore more. Perceived outcomes. This is a long-term, ongoing study. Johanna Wangdell, PhD, Gothenburg, Sweden, has focused on this, and this is a very solid Canadian occupational performance measurement studies over time that has been going for decades. So that is a good way of also knowing what's going on in your own unit. So once we keep that, we can be sure that the patient, at least they are happy with their performance and satisfied with how it's undertaken. When it comes to the third leg of what we're doing, the spasticity treatment, yeah, that can be done in a relatively simple lengthening procedure. Here we have a spastic wrist flexor that is released and followed up by measuring preoperatively and postoperatively the ability to follow the periodicity of a metronome, like one revolution, one full range of motion per second. And you see preoperatively the range of motion is very limited and it's unpredictable in terms of frequency, and that is quite different a year later. So this is an example of a simpler procedure that after several Botox injection just give a reliable result in a relatively easy matter if it's single. Very often it's not. It can combine with a pronator, and it combined with the superficial finger flexors and the thumb adductor, etc., which can also be addressed the same way. A modern approach, which is not fully evaluated, is the selective neurectomy that needs to be follow up until we can say exactly what's going on there. So then I come to this illustration of the suture. This is a suture technique that we are using and reproducing. So we come with the donor muscle through an incision in the recipient tendon and then lock it in a position and do the testing of the tenodesis during surgery. And then we do this side-to-side cross stitches along both sides over a 5 centimeter overlap. This is absolutely mandatory in our unit, that every single surgeon has to swear to God, whoever, that we're doing exactly the same thing over and over again. So at least we have one factor that it's not surgery dependent. Because if we have a failure or we have a problem, we must know that this is not the factor, or it has to be isolated. So this is our technique. And that is well tested, and we have compared it with a PT, that's not physiotherapist, it's a pulver taft suture from UK, which is sort of an intervening type of suture connection. And this is twice as strong, and that means 200 newtons plus, which is more than 20 kilogram, which allow a full flexion. For example, when we are using this in finger flexion restoration, full flexion and full passive extension with a safety factor of 5 to 10. Because a full active flexion without loading, that is maximum 40 newtons. And the full extension will put about 20 newtons load on the finger flexor. So we have 5 times or 10 times security factor that we can tell the patients, this is why your physio is so aggressive with you. That's because we know this is safe enough. So the reconstruction is finger flexion, thumb flexion, hand opening, which is pretty much an intrinsic issue, and the wrist balance. We need to get rid of the radial deviation of the wrist in order to direct the power straight forward. So our sort of workhorse is the alphabet procedure, which is combining everything in one setting. That can be adapted depending on reinnervation from nerve transfers and also the level of the lesion, of course. With higher level of lesion, fewer motors are available, and then it's a slightly different approach. But we have this procedure, 7 different sub-procedures constituting this reconstruction. And we called it alphabet because it sounded so cool to have advanced balance, combined digital extensor flexor grip. So IP stabilization of the thumb, it can be the kiwi procedure that you don't agree it's a kiwi procedure. We can call it New Zealand if that is a better word. But it's a split FPL into the EPL tenodesis to prevent the hyperflexion of the IP joint because you're reconstructing the thumb flexion. So that is important to balance that. The balancing of the hand position, well, that serves two things. One is the intrinsic securing the flexion of the MP joint of the fingers, and that means that the thumb has fingers to connect with. The index finger and balanced in a flex position secure the key pinch after the reconstruction. And secondly, while flexing actively with a wrist flexor or by gravity, the wrist will open the fingers because of the PIP extension. Positioning of the thumb, that comes also in different flavors, depending if you have done a successful spin procedure before. That may add an APL, abductor pollicis longus, an EPL, EPB. It may add enough stability not to do the fusion. Otherwise, you have to do the fusion unless you have some sort of tightness in this, or if you, it's in order to not risk the thumb going into supination, which is an outward rotation of the thumb, or flexing too early during the grasp motion. So this is our rule. We have a 30 degrees of radial abduction in the CMC joint and aiming at a 30 degrees of flexion in the IP joint. That is sufficient for opening of the thumb during wrist flexion, and also a good contact surface between thumb and index. Key pinch. Thumb flexion, that is typically provided by the brachioradialis. That's a good motor for that. It's expandable because we have two other elbow flexors available. And by moving it into the thumb flexion, we still have some pronation moment arm for this motor if the pronator teres is not present or not functioning. The finger flexion, that is typically an ECRL, extensor carpi radialis longus into the finger flexor, deep finger flexors at the level of the wrist, excluding the little finger. This is important because the little finger flexor is so tightly connected to the ring finger so that it comes passively together with it. If you include it in the transfer, it has too short journey to travel, so it will close the fist first, and then the patient approaching a handle with the wheelchair will close the fingers too early and not come around the handle in the correct way. This is opening of the hand when we do not have thumb extensors. Then we may have to rely on the passive flexion of the wrist and then the extensors balance so that the thumb will open. This is also something that is typically reinnervated with a spin procedure. Wrist stabilization, the same. Then ECU, extensor carpi ulnaris, may be shortened this way, just a simple loop, and then flipped and sutured to itself. That will shorten it and will bring it into more of a neutral or ulnar deviation instead of a radial deviation. Or more successfully, a more physiological is a reinnervation of the ECU to balance the wrist. Okay, training postoperatively, right on. That is happening the day after surgery when the muscles are fresh. I mean, we're using good donors, so why not use them from the beginning? And we trust the sutures. So that means that we prevent the atrophy by immobilization. We do the motor relearning when the muscle is as happy as possible. And we facilitate the gliding by preventing adhesions. So this patient is now training the new function with the flexion of the thumb, flexion of the fingers. They're not allowed to go all the way because We have to protect the intrinsic, passive intrinsic. You see the therapist is restricting the wrist extension during this training session in order not to go into the preoperative tenodesis grip. We want to get rid of that. We have new motors now. Or this patient is doing 2 weeks after surgery, doing ADL training, much more complex motions. This is the scary part of this movie. But getting sensory feedback and learning how to integrate that in an activity. Nerve transfers, yes, we have heard already in different workshops here about that. I just want to mention that we are very keen on understanding preoperatively what kind of expectation can we have on this surgery. Well, that is depending on the degree of the level of the lesion, of course, the degree of motor, lower or upper motor unit lesion. We can also address preoperative training, for example, building muscle bulk to get rid of a pain problem in the shoulder or strengthening in the rhomboids. We can use it post nerve transfer to help the patient over the threshold, that is using the EMG triggered muscle electrical stimulation. What is going to happen with the denervated muscle, whether it's training, well, that's part of Ines Berg's PhD project. That's up to her to respond to that question. Adhesion treatment, also efficient with electrical stimulation because you can get into the extreme positions. Muscle contracture, typically for the MCP joint, I would say, is useful. So this is one of Ines' studies that is just mapping the exact position. And you can see the standard deviation or the variation is extremely limited. So this is solid, scaled position of this. This is in Spinal Cord, published this year. So this is what you can expect when you have combined electrical stimulation. This patient is still using a little bit of wrist flexion for the opening early after the reconstruction. The outcome typically for this 30-plus patient is it's good. I mean, grasp release test is a very solid way of measuring how fast, how skillful the patient is. And this is a good example of this. This patient to the left, well, it's the same patient, but to the left is preoperatively. And he had a very subtle indication for surgery because he wanted to be more skillful, but he had quite, if you look at him, he had quite good skills on the left side before, but he wanted to be more skillful at work, which was work as a clerk. So he had a tailored reconstruction of his hand function. And you can see quite easily that he has improved in skill level, but you would probably not consider this surgery in all patients, but he was so motivated, so driven, and so focused. So he did it and did it extremely well. I think it's a very good example. So picking the paper clips, it's pretty advanced. Okay, we're moving on to next, and I just love this movie. She wanted hand function. This teacher wanted hand function on the right side to be able to draw on the whiteboard for her students, and you can see her frustration. And this is a grip reconstruction. I mean, this is a major upgrade, and I think that sort of shows the value of this service. I think it also shows the indications, but also the need to incorporate all of us to become the future of this field, expanding it when necessary, whatever means we need to do that with. I mean, it could be spinal cord stimulation, it could be surgery, it could be whatever, but this is one of the tools that I wanted to present today. Thank you very much.